If you're over 40, this is relevant to you now. If you're under 40, it's relevant to you in the future. And if you're over 40, almost everyone in this room over 40 has hypertension, which is why hypertension is a meaningless diagnosis. So, and this is what I want to explain. So I've spent the last now almost 35 years trying to get rid of the term hypertension because it's meaningless. And I'll try and explain to you why. Even though many of you in this room will have been diagnosed with hypertension, and quite a few of you will be taking drugs called antihypertensive drugs. I don't use the term hypertension except in a talk like this. I don't use the term antihypertensive drugs. I talk about blood pressure, raised blood pressure and lowered blood pressure, and drugs that lower blood pressure. Also about lipid-lowering drugs and statins. So everything I'm going to talk about related to blood pressure and hypertension also relates to high blood cholesterol or high blood glucose. I think diabetes is a meaningless diagnosis as well. Now, to explain... Actually, it's good to have, I should start the timer, because this could take all day, but it won't. So just to explain, so this picture here is called a multivariable cardiovascular risk prediction chart. Now, every one of those colours there relates to your risk of having a heart attack or stroke in the next 5 years, and it's per 100 people. So the red is bad, and blue is good. And if you look at these blocks, so each of these blocks going down the page is a different age group, 70, 60, 50, 40. And going across, these are people with no diabetes, and there's non-smokers and smokers. These are people with diabetes, non-smokers and smokers. And as you go across and as you go down, it gets redder. Now, within each of these blocks, they have, they're differentiated. These colours, this is blood pressure from low to high, and this is lipids from low to high. Now, and there's one of these for men and one of these for women. I can't remember whether this is for men or women. I could probably work it out, but I won't. So what this chart shows you that if you look at blood pressure, it goes, and that's a high blood pressure, that's a low blood pressure. So if I just take a middle of the road blood pressure, 140/85, it can be blue, it can be purple, it can be light blue, or if you come across here, it can be red. So the same blood pressure can mean you've got a risk of over 30% of having a heart attack or stroke in the next 5 years, or less than 2%, the same blood pressure. And before I started working in this area, most doctors around the world were treating people with a blood pressure over this level. If it was above that level, you got treated. If it was below that level, you didn't get treated, whatever else happened. So almost irrespective, that it was being used as a way of identifying people at high risk, but it was completely wrong. It's completely wrong, because this is your risk, and that same blood pressure could mean all of those things. And the reason is because your blood pressure alone is only one of at least half a dozen, if not more, factors that you have to put together. Your risk is determined by all of these factors, not just one. And yet smart people, doctors, were making these incredibly crude decisions based on one factor. And so we've actually known this probably since the 1970s, but no one really did anything about it because it was so easy. Just measure someone's blood pressure. If it's above a certain level, I have a drug. I can lower that blood pressure. It was a nice, simple message, easy to communicate, but wrong. And I created this chart in the early 1990s from a multivariate risk prediction equation. And what I did was try to turn this complex multivariate thing into a simple picture. Okay, and from the early 90s, every New Zealand GP was given these charts, which meant that by measuring a few factors, you could, within minutes, create or tell people what their risk of having a heart attack or stroke over the next 5 minutes was. In the next 5 minutes. That would be great, wouldn't it? Okay, sorry. In the next 5 years. In the next 5 years. So, so this is why hypertension is meaningless as a construct. You need to look at blood pressure in association with everything else. Okay, it's the only way to do it. And the other reason, it's not only tells you about your risk, but the benefit of treatment. So this is a person who's got a 20% risk from one of these charts, 20% risk of having a heart attack in the next 5 years or stroke. This person has a 10% risk. This person has a 5% risk. Now we have very common, cheap, safe treatments that can basically halve that risk. So I can give exactly the same treatment to that person, and that person. And this person's risk goes from 20 to 10, this from 10 to 5, this from 5 to 2, and so on. So exactly the same treatment is much, much more effective and cost effective up here. Everyone gets a halving of a risk, but a halving of what? Okay, so this is incredibly important for making clinical decision because it determines the size of that effect. And traditionally, we've been treating a lot of people with hypertension who were down here. And we were not people, there were people up here who didn't have hypertension because their blood pressure was lower than that, who weren't getting treated, but would have benefited hugely from treatment. Because we've all got hypertension, because anyone, well, most of you, if your systolic blood pressure is greater than about 115, then you would actually benefit by having it lower. But it depends on all those other things, how important it is to lower it. Okay, so that's important. So that chart I showed you, which I developed, came from American data from 5,000 Americans who were identified in the 1970s and followed for about 20 years. And the key question when I developed these charts, and it was a good question, was the only data available at the time when I did this in the 90s, how relevant is a US study and a US risk prediction chart like this to a multi-ethnic New Zealand population in the 21st century. So in the early 2000s, I set about leading a study which is now was published in 2008 in Lancet, where we recruited 500,000. We've now recruited over 500,000, but we had 400,000 people, and we created these new risk charts based on New Zealanders that include ethnicity, Māori, Pacific, South Asian, also include deprivation. So we're one of the first countries in the world to include deprivation in our risk charts. And these risk charts, you can go find it. If you're over 40, you probably have had your risk assessed using Predict, which is this tool we've generated. But this is a Canadian website that actually has our equation up on it. And if you do go to this website, be careful to go to it says, where do you live? And if you're in New Zealand, click Predict. And by plugging in those data, it will tell you what your risk of a heart attack or stroke is in the next 5 years. And as I said, if you're over about 40, you probably should know what this is. And if you don't, ask your GP and talk to your GP about, one, what your risk is, and what the benefit you would gain from lowering your blood pressure or lowering your cholesterol. I'm done at 1 minute to go. So anyway.
Fantastic, another exciting talk. How many people are going to check out the website?
Check it out after a staff meeting.
So we do have time for questions. So,
Peter.
Hi, Rod. One of the issues with the way we approach these diseases at the moment is to treat the symptoms rather than the cause. And in the modern world now, we have these wonder drugs that all the stars are taking, Ozempic and so on, which are proving to really almost be a one-stop shop for preventing or getting the cause under control. So what's your thoughts on on using treatments to prevent rather than just treat the symptoms?
Yeah, well, I mean, let me just be clear that I'm talking about if we, the direct or the almost immediate cause of a heart attack or stroke is a raised blood pressure, raised lipids, all of those things. But are you talking more about the causes of the causes? Because, I mean, if...
Within 5 years now, you could greatly lower your risk by taking Ozempic.
Yeah.
Even if you're a relatively thin person.
Yeah.
So that's addressing the causes.
Okay.
Not lowering the lipids or lowering the blood pressure, which are the symptoms.
So what you're saying, basically what you're saying, Peter, is that rather than wait till people have got raised levels of these risk factors and lowering them, actually treat them before they even get to that. Along those lines. I guess as I'm both trained as a clinical doctor, but I've also trained as a public health doctor, and I'd even go back one step further. Now, who is this? This is me, by the way. Well, I'm 70 next month, and this is my risk at 7.4% in the next 5 years. Now, I'm interested in the causes, so I'm not particularly overweight. My blood pressure is okay for someone my age, and my lipids okay, not bad for someone my age. And that's because I'm interested in the cause of the causes, so I eat a diet low in saturated fat. I try not to eat too many calories, I don't smoke, and I take regular exercise. So one step before what you say, I'm is equally focused on the causes of the causes, but you're talking about that intermediate step, which I think is very interesting, is that should we be treating not only preventing people from getting overweight or through lifestyle changes, but actually talking about intervening earlier with these drugs. And I think, when I started working in this area back in the 90s, one of my motivations was statins. Back then, there was a guideline that suggested that people with a cholesterol over a certain level, again, this dichotomous thing with the risk factors, which was wrong, should be treated with statins. And I worked out it would cost the entire drug budget in New Zealand if we followed those guidelines. So that was one of my motivations to treat the right people. But now these drugs are really cheap. They're cents. It costs a few cents a day to take a statin, or even less. And they're incredibly safe and effective drugs. So there is interest, and there are people who suggest that once you reach a certain age you should go on a statin. Now, as it happens, I was planning to go on blood pressure lowering drugs at the age of 60, but then I did my own study and found that the American chart overestimated my risk by 50 or 70%. So I'm still waiting for my risk to get high enough for me to go on these drugs myself.
I think we have time for one quick question if anybody has one.
They're all going to go.
Wait for the...
Thanks for that very entertaining and helpful talk. I'm looking at the one on the right. None of the boxes are ticked, so you choose the options there. So you can have a medication on the right, the other right.
Oh, this one here.
Yeah.
Oh, this is the next side. I haven't covered this is the treatment side.
Yeah.
So you can actually look. So this here, yeah, you can't just choose anything here. Of course, you have to. But once you've got your risk profile, it'll estimate your risk, and then you can look at here. And if you click these various things, it will actually tell you how much benefit you get.
Yeah, that's what I was looking at.
Yeah.
So the non-drug choices, a Mediterranean diet and physical activity that doesn't involve shouting, whether that can actually lower your probability of whatever 7.4% is.
Yeah.
You haven't revealed which are.
No, I haven't revealed which ones
that
I
would be
do.
too personal.
Yeah. But you can play around with that, but just make sure that you use the right click where you live to make sure, because there are a number of other charts in there, an American one, a UK one, and another European one, which will give you the wrong risk, whereas the New Zealand one it's the best risk data for New Zealanders. Yeah.